Thanks, Dr. Gleave, and good morning, everyone. So for my final grand rounds of residency, I'll be straying from my streak of talking about radiation. And as Dr. Gleave mentioned, I'll be looking at health economics and more specifically, cost effectiveness. So I'll start by reviewing some of the terminology and principles used in economic evaluations, which can be muddling since some of the terms are used interchangeably or occasionally erroneously. I have some examples of cost effectiveness analysis specific to urology, which are not exhaustive, but chosen because they're common or interesting or instructive. And I'll conclude by looking at some of the strengths and limitations of cost effectiveness analysis. And of course, the most important objective in any economics talk is to not let the audience fall asleep. The study of economics is fundamentally an optimization problem, looking at the relationship between means and ends, where the means are often scarce and have alternative uses. This is certainly true in healthcare. There's an increasing discrepancy between means and their alternative uses. The figures here illustrating the rising per capita spending and spending as percentage of GDP in Canada over the past century, highlighting how more and more of our economic resources are being committed unsustainably toward healthcare expenditure. With further exacerbation from the COVID pandemic and the imminent gray wave or silver tsunami of aging boomers, we're all familiar with the headlines regarding the financial healthcare crisis. So quantifying these means and uses or supply and demand highlights the scope of the problem. We may be familiar with studies reporting the burden of disease in terms of dollars per year or dollars per patient. These are so-called economic impact or cost of illness analyses, and that's not actually our main focus today. We'll be focusing more on the microeconomic evaluations used for decision-making in allocating finite resources, especially cost effectiveness analysis and what's known as cost utility analysis. These can improve the efficiency of our resource allocation, helping us get the best bang for our buck or value, and in turn help combat that discrepancy between supply and demand. This is also where, as physicians, we have the potential greatest impact. So the underlying principle behind these evaluations is that with finite resource, you simply cannot choose all alternative intervention options. There's an opportunity cost, a loss of potential gain with some options. Therefore, it's not sufficient to establish effective outcomes alone. The outcomes for each intervention must be weighed against the associated costs. Doing so for all alternative interventions allows for systematic comparison, aiding optimal decision-making and resource allocation. Evaluations are often performed at a disease level, as crudely illustrated here, comparing different treatment classes for a particular disease, surveillance versus medical versus surgical management. Comparisons can also be made between different treatments within the same class, different medications. This extends to various screening, diagnostic, or surveillance pathways. And the same principles can be applied even at a program level, for example, helping to allocate resources between primary care versus cancer care versus cardiac care. So what's the relevance to us as clinicians? I think on a basic or individual level, there's some evidence that we as physicians have direct or more commonly indirect control of up to 80% of healthcare expenditure. And we never forget our roles as medical experts, health advocates, and scholars, but I think it's equally important to remember that we're also managers and stewards of the healthcare system. Importantly, there's also increasing oversight at the institutional and regulatory level. And the chief mechanism is through the expanding role of health technology assessments, or HTAs. These are multidisciplinary teams tasked with integrating cost effectiveness, budgetary, social, ethical, and legal considerations in advising policymakers. And the cost effective analysis is often the crux of these reports. Perhaps the most prolific agency performing these HTAs is NICE in the UK, but our Canadian counterpart is CADITH, and here in BC, the HTAC. Interestingly, there's no major regulatory equivalent in the United States, and cost effectiveness is not a consideration of the FDA. Their resource allocation has historically been driven by health plan reimbursements, market demands, and physician preferences. However, HTAs are increasingly common at an institutional level. For example, Kaiser Permanente has a well-established and quite effective medical technology assessment committee. This increasing profile of HTAs and cost effectiveness considerations has in turn driven more and more explicit or rigorous methodology for quantifying value, and it's also driving more incorporation of economic analysis into clinical trials. And I think it's important for us as physicians to have some familiarity with respect to what goes into these HTAs and economic valuations, especially if we're going to have a voice at the final decision-making table. Often these HTAs have a limited input from disease content experts, but nonetheless, they can really shape how we deliver care. So what are the different flavors of these economic evaluations? As mentioned, we're focusing on the cost effectiveness analysis and cost utility analysis, but there are a couple other methodologies not infrequently encountered. All compare costs and outcomes, where costs are always a monetary variable. So it's the outcomes that determine the type of evaluation. These cost consequence analyses are reports of multiple disaggregate outcomes rather than one primary outcome. They're used when it's clear, when it's unclear which is the most important outcome, or no information is available on the most important outcome, and it's difficult to draw meaningful conclusions. Cost minimization analysis is a historically popular methodology. It assumes identical outcomes between options, perhaps if a trial demonstrates equivalency, and then focuses solely on the cost. It's no longer recommended and fallen out of favor. And cost-benefit analysis further generalizes outcomes by monetizing them. It's a more abstract analysis that allows comparisons outside the scope of healthcare. So cost effectiveness and cost utility analysis, the terms are used interchangeably often. In particular, cost utility analysis is often referred to as cost effectiveness and lumped under the same umbrella, even in this presentation. Both account for differences in cost and outcome. The differences in cost effectiveness analysis, the outcome is traditionally measured in natural units, are typical measures of clinical research, case detection, disease-free survival, overall survival, life years, etc. While in cost utility analysis, outcome is measured in more universal units of utility, such as quality adjusted life years. These are the most used methodologies, and cost utility analysis is really considered to be the standard. So looking at the outcome side of the scale, we've already discussed the natural units of cost effectiveness analysis. These are drawn from trials and systematic reviews, but I think utility measures deserve a little bit of elaboration. So how are these determined? Well, for each health state, for example, disease-free, recurrent disease complication, the associated quality of life is captured using a validated survey instrument such as SF36 or EQ5. And then the key step is really to map each quality of life score into a utility score. Utility score ranging from 0 to 1, where 0 is equal to dead, 1 is equal to complete health, although you can theoretically have utilities worse than 0. This is the most challenging step. It's accomplished using health state preference methodologies. As an example, inferring from a series of questions requiring choices between different health levels and life expectancy. And the QALYs are taken from survival time in that health state multiplied by the utility of that health state. So one QALY is 1 year of perfect health. This captures an important dimension beyond survival. It also allows comparison between apples and oranges, i.e. alternative options with complex or different outcomes. Economic evaluations usually draw the survival data and utilities data separately from the literature and then combine them in the analysis, unless, of course, the data is obtained simultaneous in a trial. So the figure on the left here just summarizes how QALYs are aggregated over a disease course with 3 health states, ABC. For each, survival time is measured, the quality of life is measured, and then mapped to a utility, and they're multiplied. And the other figure just highlights how QALYs capture an important dimension beyond survival. Here, the survival is 50% longer for the second intervention, but the QALYs are over double. Okay, moving on to costs and looking at the other side of the scale, there are a couple methodological points to touch on. First, whose costs are we considering, or the perspective of the analysis? Most often, especially in health technology assessments, the perspective is of the payer. The Ministry of Health is focused on its own costs. But on occasion, and arguably not frequently enough, this is brought into society as a whole and considers costs to patients, caregivers, employers, and the burden on social services. Next, how are the costs being counted? There are broadly two contrasting approaches. Microcosting is so-called bottom-up approach. All costs are fully itemized down to disposables. This is a more precise and less subjective to bias, but very resource intensive and often impractical in our system with poor accounting and silos of care, unless it's tied to a clinical trial. Conversely, gross costing takes a top-down approach. Costs are derived from so-called bundles of care, discrete healthcare events, such as a procedure or admission, with established representative costs. This is more efficiently, but inherently less precise and more subject to bias. Lastly, where are the costs being counted? While outcome data is typically generalizable, cost data is much more jurisdiction specific. For this reason, even within Canada, individual provinces will perform independent HTAs. You need to take caution applying foreign analyses. There are also a handful of accounting adjustments which need to be applied, discounting inflation and currency conversions. The costs are established in two steps. First, all relevant resource use is identified and quantified, where relevance is, again, determined by the perspective. And this is accomplished prospectively through clinical or observational trials or retrospectively through administrative data. Resources typically fall into these main categories. Next, monetary value or unit cost is assigned to each resource. Again, this can be derived from primary data collection or alternatively from some of the published sources listed here. Briefly touching on the Canadian Institute for Health Information, this is an agency which collects inpatient data from across the country and then classifies each admission into one of 528 case mix groups. It also estimates costs of standard hospital stays. It's akin to the diagnosis-related groups, or DRGs, used in the United States derived from Medicare, and it's a very common top-down approach to costing. So how are the outcomes and costs then compared? In general, in two ways. Evaluations associated with trials are typically straightforward calculations using the outcomes and costs quantified in the trial. But if trial data is not available, modeling used. Even when trial data is available, modeling has some advantages. It allows for consideration of relevant alternatives beyond those limited to the trial arms. It allows for extrapolation beyond the trial time horizon, and it allows for generalization of trial protocols to the real world or to different jurisdictions. The basic steps of modeling are to choose the model type, the appropriate time horizon, models then populated with parameters for outcome and cost, as we've already discussed. And it's also important to establish the probabilities of each clinical event occurring. The two most common model types, without getting too bogged down into details, are the decision trees, which are chains of events regarding all possible series of events, representing all possible series of events, where associated probability, outcomes, and costs are summed for each pathway and then compared between interventions. And these Markov models, which represent all relevant health states and the associated outcome and cost, as well as all possible transitions between those health states and the associated probabilities. Then a separate model is constructed for each intervention, and the outcomes and costs are accumulated as the model iterates. So what is the end result? It establishes the incremental cost effectiveness ratio, the difference in cost over difference in effectiveness. And this is the standard unit of measure in cost effectiveness analysis. It's represented graphically on a so-called cost effectiveness plane, where the slope is the incremental cost effectiveness, or ICER, and the interventions landing in the southeast or northwest quadrants are the no-brainers. Respectively, they're the interventions that are more effective and lower cost, or less effective at higher cost. Typically, we're most interested in this northeast quadrant, where interventions are more effective, but also more costly. A couple notes on interpreting ICERs. The figure on the left highlights how we must be careful of the comparator. We're looking for incremental differences, and that we should be comparing to the next best option, not to the baseline or nothing, which is referred to as the average cost effectiveness ratio. As illustrated, looking at the slope of intervention B to A versus B to the origin, an average cost effectiveness ratio would overestimate cost effectiveness in this kind of case. And the figure on the right highlights how any intervention falling in this gray shaded area to the left of the cost effectiveness front is said to be dominated by the others. So what's a good ICER? In other words, what's our willingness to pay? This is referred to as a ceiling ratio. The most widely adopted rule of thumb that we hear thrown around is $50,000 US dollars per quality adjusted life year. And this is actually derived from historic Medicare costs for 1 year of dialysis. And that's the origin of that number. It's not an exact science, though. In fact, the topic of how this number should be established is greatly debated. But in general, ICERs trending down towards $20,000 per quality are widely accepted, while those reaching $100,000 per quality are rarely accepted. NICE in the UK uses a relatively strict cutoff of 20,000 pounds per quality. Lastly, uncertainty is handled and presented in a less familiar manner in cost-effective analysis. It's important to remember it's not based on hypothesis testing, and so we're not evaluating p-values. For ICERs derived from trial data, the point estimate of the ICER is straightforward to calculate, but confidence intervals for ratio statistics are not straightforward to calculate, and we won't get into that here. Meanwhile, for ICERs derived from model data, uncertainty is introduced through the parameters as well as through the model structure and assumptions made in constructing it. In general, models should be analyzed in terms of a base case, and then subsequently sensitivity analysis is performed either deterministically by varying parameters over the plausible range of values and determining impact on results, or probabilistically by assigning each parameter a probability distribution, then running the model many times, resampling the parameters from those probability distributions each time. It results in this cloud of ICERs. These figures are very common in the cost effectiveness literature. And you're interested in what percentage of your simulated ICERs fall below your ceiling ratio, giving you the probability of cost effectiveness. Okay. So I'd like to move into some of the examples now that pertain to urology. Again, these are not exhaustive, but I thought they were common or interesting and have some instructive points. And we'll start with kidney transplantation, which is traditionally the gold standard in terms of cost effectiveness. It demonstrates superior effectiveness at a decreased cost and lands squarely in that southeast quadrant. This is a seminal Canadian paper establishing the cost effectiveness of kidney transplantation with a prospective cohort from here at UBC and at Western. These were 168 patients who were initially followed pre-transplant out to 2 years post-transplant. And this was an economic evaluation associated with an observational trial. And the final ICER was $59,000 in the first year and $394,000 in the second year. We're averaging $226,000 over the 2 years. Note that since these ICERs are in the southeast quadrant, they're negative, and the larger magnitudes are actually more desirable. A couple considerations. Interestingly, this study considered the societal perspective, which can serve to compound the cost savings once the patient, caregiver, employer, and social service costs are all considered, which potentially amplify the favorable ICER. However, they only consider a 2-year time horizon, which is insufficiently long to capture the differences in survival between attributed to transplant. It's redundant in this case since the results are clear, but nonetheless, longer time horizons with survival benefit after transplant would further amplify the favorable ICER. And this highlights the impact of an appropriate time horizon for an economic evaluation. There were a couple other characteristics of the cohort with a potential impact on the cost effectiveness. 1990s dialysis has potentially improved more than transplant over 3 decades, potentially closing the gap. And 83% of the patients were from deceased donors, but this does not consider the quality of the donors. Most importantly, this was a young, healthy cohort with only 13% of patients being over 60 years old. So what about lower donor quality? So Axelrod et al. Performed the only cost-effective analysis specifically on donor quality. This is based on modeling. And their publication actually reported the average cost-effectiveness ratio rather than the incremental cost-effectiveness ratio, which is here I've manually recalculated and plotted the ICERs relative to dialysis, and the overall conclusions are fortunately similar. Aside from HLA incompatible patients, donors are largely cost-effective, even when they're lower in quality. And we can see how the ICERs further strengthen the conclusion when they've been properly recalculated. And this illustrates how this is a common misstep, even in reputable journals. What about older age or increased comorbidity? There's certainly an increase in morbidity with transplant in terms of surgery and subsequent immunosuppression. Nonetheless, there continues to be a survival benefit as demonstrated by another seminal UBC paper. This is particularly when patients receive higher quality kidneys. However, the impact on quality of life, which could be dampened by the morbidity, and the cost, which is likely increased by the morbidity, are not as well defined. Transplantation in the elderly or comorbid patients likely ends up in that northeast quadrant. It's potentially improved effectiveness, but in most cases, but not necessarily cost effectiveness. Unfortunately, existing cost-effective analyses are inconsistent and there are significant limitations. This is clearly an area which would benefit from more rigorous evaluation. It's a very tangible example of allocating a limited resource. Next example I want to discuss is stone disease. So endourology is very technology driven with potential opportunity for improved efficiency. Furthermore, endourology outcomes tend to be quality of life driven rather than quantity of life driven. This can at times make effectiveness more challenging to evaluate, but it also precipitates interesting scenarios where we might be have more of an appetite to accept inferior effectiveness, but with decreased costs, i.e. ICERs in that southwest quadrant. A great example is shockwave lithotripsy versus ureteroscopy. And to this end, we'll start by looking at 2 separate cost analyses of SWAL versus URS for ureteric stones. One American from Cohn et al. And one British from Constanti et al. These differed in their costing approach. The American study was based off a single center experience, took a more bottom-up approach. Meanwhile, the British study used NHS reference costs, i.e. published bundled costs, or a more top-down approach. immediately we see that there's quite a discrepancy between the relative cost per treatment of SWAL versus URS. A couple considerations to take into account for these cost differences. They could be attributable to the costing approach. In general, bottom-up approaches are considered more precise, but then there could be additional costs missed by using the NHS references. An important consideration with surgical technology is the handling of capital costs. Large upfront costs for big ticket items such as lithotripters or lasers are often mishandled in economic evaluations, and care needs to be taken to identify how they're being amortized and how the per case costs are being calculated. In general, centralization improves cost effectiveness when it comes to significant capital costs. In this case, single large regional lithotripter, which is constantly being used, which is more likely the case in the UK, will be more cost effective than one of those small portable lithotripters. The counterpart to capital costs of variable costs, which usually take the form of disposables. There can be high variability, particularly in ureteroscopy, especially with different laser technology stenting practices, and if the stents are removed by cystoscopy. Often, this is where we as surgeons have the greatest impact, but it's unclear if it's a driver in this situation. I do think jurisdiction plays a really important role here. The US is generally an outlier for SWAL reimbursement, as US reimbursements are disincentivizing modalities requiring repeat treatments, therefore favoring ureteroscopy. And I think our findings in Canada would probably be more in line with the UK. And as we've discussed already, the perspective affects the cost. Again, this is not a driver in this situation, as both took a similar perspective. We're also discussing cost per single treatment for now. But once we start considering retreatments, patients' costs, productivity costs could potentially favor ureteroscopy. So using these per treatment costs, both studies then considered pathways achieving stone-free state for patients with ureteric stones, starting with either an upfront shock SWAL or ureteroscopy. Cohen et al. Favored not retreating with SWAL and using their cost data and stone-free rate from their own retrospective cohort of 130 patients. They concluded that SWAL was more expensive unless stone-free rate was greater than 60%. Meanwhile, Constanti et al. Favored trying shockwave lithotripsy again if it initially failed, and they took their base clinical parameters from the systematic review. They also performed a sensitivity analysis, finding that SWAL was less expensive across stone-free rates and across ureteroscopy stenting practices. So an important caveat is these studies assessed cost, but despite different possible care pathways, they achieved uniform binary final outcomes. All patients were stone-free. They're not a formal cost effectiveness analysis or a cost utility analysis. There's missing information. In these studies, any differences in outcome were only reflected in the cost, but also could have contributed to quality of life in terms of the procedures themselves. Patients having SWAL suffering with Steinstrasse, patients having ureteroscopy suffering with stent colic, as well as the need for retreatment and the time taken between those retreatments. So Colonzo et al. Recently performed the first cost utility analysis on this topic, which was performed alongside the TCU randomized controlled trial of upright shockwave lithotripsy versus ureteroscopy for ureteric stones less than 1 centimeter. So 613 patients across 25 UK centers. And the clinical outcomes, the quality of life for the analysis were acquired from the trial, while the costing was acquired from NHS perspective. The resource use was also acquired from the trial. However, the unit costs were still taken from NHS references. So it was a mix of bottom-up and top-down costing approaches. And indeed, shockwave lithotripsy was less effective, but less costly. And overall, the ICER was cost-effective. There are some analogous findings for smaller renal stones, though no similar level of evidence with trial-based cost utility analysis. And I think the situation becomes more complicated as we consider medium renal stones, especially considering emergent ureteroscopy technologies such as the thulium laser and PNL technologies such as mini or micro PNL. The final example I wanted to discuss are in bladder cancer. And this is because bladder cancer is a particularly heavy hitter in terms of resource use. In fact, bladder cancer is associated with the highest lifetime cost per patient of all cancers, ranging from around $90,000 to $200,000 per patient from diagnosis to death. A substantial portion of this cost is attributable to non-muscle invasive bladder cancer, driven by the need for ongoing surveillance and recurrence management. Furthermore, there is marked inter-provider variation when it comes to non-muscle invasive bladder cancer management, ranging from $4,000 to $7,000 per patient per year. In fact, provider might have a greater impact on cost than stage or grade, and unfortunately, these costs have not been associated with differences in outcome. Halpern et al. Looked at cost effectiveness of imaging in asymptomatic microscopic hematuria workup. They performed a true cost effectiveness analysis. The outcome measured here is in natural units of cases detected. This was a model-based analysis with clinical parameters from the literature and costing from Medicare, taking a payer perspective. And their figure here has an inverted axis with cost on the X and effectiveness on the Y. So it's flipped from what we'd normally expect to see. However, they nicely illustrate the cost effectiveness front and how adding renal ultrasound to cystoscopy has an ICER of $53,000 per case detection, while adding CT-IVP has an incremental cost effectiveness of $6.5 million per case detection. These findings were also consistent across groups with higher risk, males, older patients, and smokers. The study certainly has some limitations, namely their outcome measure and limited horizon don't account for the impact of the missed cases or for radiation effects. And these results feel somewhat self-evident because they're now reflected across guidelines. However, the AUA guidelines were only updated in 2020. And in fact, they directly cited this study. Prior to that, universal CT-IVP was actually considered acceptable, and largely because it was considered safer. I think it's not uncommon to justify inefficient practices which are perceived as safer, but economic analysis can really draw attention to the magnitude of waste. I suspect a lot of the trimmable fat within bladder cancer lays within lower risk non-muscle invasive bladder cancer. Hussein et al. Performed model-based cost utility analysis to compare office-based fulguration versus transurethral resection in the operating room for lower risk non-muscle invasive bladder cancer. This was based off outcomes and costing at Memorial Sloan Kettering, and they found that not only was office-based fulguration less costly, it was also more effective, driven by the improved quality of life, squarely falling in the southeast quadrant. Again, this is a negative value because it's in that southeast quadrant, and because it's larger ICERs in this case are more favorable. Green et al. Extended this to incorporate single-dose intravesical cycle chemotherapy. Again, a model-based cost utility analysis this time using Medicare data for costing. Of note, their intravesical cycle chemotherapy drug cost was $158, which is important to note because there are such disparate potential costs here. This was another study which actually based its conclusion on the average cost effectiveness ratio, or ACERs, rather than the ICERs. And in fact, it resulted in a misinterpretation of their results, claiming that fulguration alone was most cost effective. Indeed, fulguration dominated operative TUR, as seen in the Hussein study. However, the ICER for fulguration with intravesical chemotherapy relative to fulguration alone was $4,000 per quality of adjusted life year, which suggests it's cost effective. Furthermore, if you use their data to consider TUR plus IVC relative to TUR alone, the ICER was only $1,900 per quality adjusted life year. again, reinforcing the cost effectiveness of intravesical chemotherapy. Lastly, I wanted to look at cystoscopic surveillance in non-muscle invasive bladder cancer. In general, surveillance schedules for many diseases are not based on strong evidence, and they may be ripe for optimization. NICE published the only cost-utility analysis of surveillance in non-muscle invasive bladder cancer with their 2015 guidelines. This was a model-based analysis using NHS references for costing and a 10-year horizon. And they took the standard practice surveillance schedules at the time for low, intermediate, and high-risk non-muscle invasive bladder cancer and compared them against hypothetical schedules with slightly or significantly reduced frequency. Unsurprisingly, for high-risk disease, the standard practice intensive surveillance was most cost-effective, driven by early diagnosis of progression. Also unsurprisingly, for low-risk disease, significantly reduced frequency of surveillance was most cost-effective. And we see this de-escalation of surveillance now reflected across guidelines. But I think it will take some time to disseminate into practice. I think this is another example where perhaps a wasteful practice might linger because it's perceived as safer. I think the interesting results were the suggestion that it might be similarly cost-effective to a degree de-escalate surveillance in intermediate risk as well. They also explored intrarenally replacing cystoscopy with urine-based testing. And there's certainly a great deal of interest in this potential for cost effectiveness since cystoscopy is so resource intensive, but there are no unanimous winners to date. So I'd like to wrap up with some caveats and limitations around cost effectiveness analysis. One thing that really struck me when I first started to explore this topic was how can we factor in innovation? Health economic analyses seldom consider the downstream consequences of adopting a technology on further research and development. And this is largely because innovation is difficult to define, quantify, and predict. Some important considerations are the novelty. Does this technology open a new approach or new avenues new avenues of investigation? And are there spillover effects? Can it foster innovation in other domains? In the same vein, does this represent incremental refinement of existing technology or a complete breakthrough? This is more specific to devices or procedures, but how is this technology impacted by and how will it impact learning curves? And this applies more to incurable diseases, but will this technology extend life sufficiently to benefit from future advances, what's known as real option value? This importance of innovation hasn't gone unnoticed. HTAs have been encouraged to regard innovation as a social value worth pursuing, independent from maximizing health outcomes. Nonetheless, no structured methodology exists, and evaluation is subjective if performed at all. And I think innovation also goes hand in hand with the idea of dynamic pricing. New things cost more, often reflecting the research and development costs, but these prices change over time. Health economic analysis is usually performed from the current payer's perspective and seldom accounts for this phenomenon. As a nice example, the cost effectiveness of management strategies for metastatic castrate-sensitive prostate cancer from 2019 would suggest that abiraterone is not cost effective with an ICER of nearly $300,000. Only 3 years later, in 2022, during which abiraterone came off patent, the ICER declined to near $50,000 per quality of adjusted life year, while the second generation androgen receptor blockers have not yet seen this shift. One common erroneous assumption is that cost effectiveness is equivalent with affordability, but a technology can be simultaneously cost effective and expensive. Cost effectiveness analysis just quantifies the return on investment. For this reason, most HTAs also include a separate budget impact analysis in conjunction with the cost effectiveness analysis, which helps quantify the net resources required to implement the technology. In other words, it helps identify how the piece fits into the current budget puzzle. Big ticket items or big pieces are more difficult to fit into a budget, regardless of how cost effective they are. Furthermore, cost effectiveness or efficiency isn't the lone objective. As we discussed already, research and innovation have intangible benefits which are difficult to quantify. Similarly, HTAs often strive to take equity considerations into account with more flexible willingness to pay in children in at-risk populations, orphan diseases, etc. Cost effectiveness at face value can certainly be perceived as a cold or utilitarian measure. Lastly, there are a lot of poor studies out there. Cost effectiveness analysis has long suffered from a lack of standardization. It can be challenging to interpret non-standard methodologies and make comparisons between them. Fortunately, there has been a push for standardization with major journals such as JAMA publishing explicit guidelines. Nonetheless, evaluations are only as good as the data and assumptions that go into them. And cost effectiveness analysis relies on multiple data sources, the probabilities, survival, utilities, and cost information. And these can be further amplified by poor modeling. It's the old adage that garbage in results in garbage out. So to conclude, I'd like to say that cost-effective analysis is not definitive. It helps gain perspective and prioritize. It's a decision assisting, not decision making tool. As such, it requires cautious interpretation, but with its increasing prominence and relevance, I think it's helpful to be literate on the subject. At the end of the day, we're all stewards of the healthcare system. I just wanted to thank Dr. Patterson, who helped me take a look at this topic, as well as Dr. Matt Kadatz in transplant nephrology, who has a background in healthcare economics and has helped me explore this in more detail. I also took a course on this during the pandemic, actually, when I had a little bit of free time at a distance at the Health Economics Research Centre in the UK at Oxford. Thank you.